We are here today to talk about the 4 important screening tests: heart, eyes, feet, and kidneys. To have done the frequency with which when they should be done, who should perform them, and why these tests are so important to help prevent or delay diabetes complications. We're joined by some incredible, knowledgeable guests today who will be sharing their perspectives on the subject. Welcome, doctors Holden, Bajaj, Abalawi, and McFarlane. We call them our Fantastic Four. We welcome questions from the audience anytime, so please feel free to use the chat function to ask your question. So while you're composing your questions, we have some prepared questions. So let's get the dialogue started so that you could benefit as soon as possible from these amazing, amazing panelists. So let's get started. So the first question is, I'm going to be asking Dr. Holden, what should people know about the risks to heart health posed by diabetes?
Oh, thank you. So people with diabetes are more prone to developing heart disease than people without diabetes. And they also tend to develop it at younger ages than people without diabetes. They can present with heart attacks, they can present with angina, they can present with strokes. And they can also present with something called heart failure, where the heart has difficulty pumping blood and fluid can build up in the lungs. This can cause shortness of breath. It can also present sometimes with cough. So it's important for everybody to eat nowadays a low-fat diet, exercise regularly, but it's essential for people with diabetes. It's also really important that they not smoke and that they keep their weight in a healthy range.
Well, thank you so much, Doctor. And we're going to be diving a little bit more into these questions in terms of what you've answered. So we're just getting warmed up. So please prepare your questions. And we're going to be going to the next panelist, to Dr. Bajaj. How does diabetes impact eyes and vision? Are eye complications permanent in people with diabetes?
Yeah, hi everyone. And for those of you celebrating the Indian festival of Diwali, that's why I'm dressed up like this. It's the Indian festival. So about the eye disease and complications. There are 4 types of eye disease complications that can happen in people with diabetes. There's the lens, the front of the eye. The lens of the eye can develop cataract at an earlier age and more frequently in people with diabetes. But there's also the back of the eye, the retina, which can get more complications as well, which could include more bleeding within the retina. What we call retinopathy can happen, where there's bleeding and so the vision is reduced. Or there's more edema or swelling within the back of the eye as well. So what we call macular edema. And then glaucoma is also more frequent in people with diabetes. Glaucoma being blood pressure or pressure being higher in the eye as well. So those 4 conditions are more common in people with diabetes. Those 4 eye conditions is what we call diabetes eye complications. Now, some of the complications, if caught early on and treated appropriately, can actually be prevented or prevented from escalating to permanent damage. So that's what the goal should be, Siva.
Thank you so much, Dr. Bajaj. These are, again, really important questions, and we have 4 panelists here, so please prepare your questions, and we'll ask the next question about our foot care. Dr. Abulawi, I'm sure our viewers have heard a lot about the importance of foot care for diabetes. So why is this important, and how can they ensure regular testing is taking place?
Yeah, for sure. And hello from sunny St. John's. Great to be connecting with everybody here. So foot complications and diabetes are serious. They matter to people. And we've heard from people living with diabetes that the fear of developing one of those complications is even more than death for some people. And the reason it's really important to talk about it today is that we have tools that reduce the risk of developing those complications, and the majority of them by up to 85%. So thinking about just how serious they are, it can range on a spectrum from losing a toe to losing a limb, or having an infection that just puts a big bump in people's life and changes the course of needing acute care at that time. And in terms of the tools, many of the ones that we have for reducing the risk are readily available, and there's the diabetes team to support with that. So how can people ensure regular testing? I think step number one, being informed. So with everybody being here, we'll share that the basic and standard diabetes care is having a foot exam, a diabetes foot exam at minimum once a year. And the goal of that is to find out where people lie on that risk spectrum. So is it in the low risk category, moderate, or high risk category? And because that risk can change over time, again, at minimum once a year. So maybe, inquire if you're up to date on your foot exam, maybe see your family doctor, a diabetes educator, a podiatrist, or someone who's trained in diabetes foot exams.
Thank you so much for the answer, Doctor. We'll be asking Dr. McFarlane about kidneys. So what makes kidney health so important for people with diabetes, and what are these tests, and then what are we really looking for?
Okay, great. Thanks, Eva, and hello, everybody from sunny Toronto, I guess. So, of course, I'm biased being a kidney doc, but I think for people with diabetes, this is for sure one of the most important complications. It's certainly one of the most common. So about half of everybody with diabetes will show some signs of kidney damage in their lifetime. If you came with me to my dialysis unit, about 40 to 50% of the people on dialysis are there because of diabetes. Now, of course, most people with diabetes who get kidney involvement don't progress that far, thankfully. But the testing is important because, as mentioned by some of the other speakers, when it comes to the kidneys, we have things that can prevent kidney damage. And if there is established kidney damage, there are things that we can do that can slow down further progression of kidney disease in people with diabetes. And the final thing I just wanted to mention is that most people who have kidney damage have no idea that they have it. Unlike something dramatic, like a change in your vision or a heart attack or a stroke, kidney disease is by and large silent. And most people don't know that they have any problems in their kidney until they're down below about 10% of normal kidney function. So we really do need to test in order to catch the disease at all, but in particular if we want to catch it early. So the two tests that we do, we check the urine for extra protein, because we can see extra protein for years and sometimes even decades in a person with diabetes before they actually start to lose kidney function. So for many people, that first sign of diabetes affecting the kidney is going to be extra protein in the urine. The test of choice is the random urine albumin ratio, or ACR. And we also check the blood for the level of creatinine in the blood. Creatinine comes out of the muscles, filtered by the kidneys. The higher the creatinine, the lower the kidney function. So we combine these two tests to check for early kidney disease, moderate and late kidney disease, the random urine ACR, and the blood test for the serum creatinine.
Thank you so much, Doctor. We have a question about cholesterol. Dr. Holden, how often do you recommend testing for cholesterol, and is once a year good enough?
So typically cholesterol levels are checked once a year, at least once a year. If you're on cholesterol lowering medication, though, your doctor will probably check the levels at each visit. And they typically are looking at something called the LDL, or bad cholesterol. I want to see it under 2. If you've had a heart attack, they'll aim for an even lower level, typically under 1.8.
Thank you, Doctor. Dr. Bajaj, can you have type 2 diabetes and not have any eye issues?
Yeah, so that question. And so when I counted the diabetes eye disease, those are conditions that we want to prevent from happening. So over the past, especially the last 2 decades or so, the diabetes, eye conditions, eye diseases that we talked about, the four things. So especially the diabetic retinopathy been reduced over time. So the portion of people who get these complications is much less. So it is absolute possible, and actually the right approach, the right target to have those diabetes, eye disease complications. And how we do that, there's three things to keep in mind. One is screening. So screening should start right away in people with type 2 diabetes as they're diagnosed. That's what the Diabetes Canada guidelines recommend, is that diagnosis, and at least every 1 to 2 years thereafter, even without any symptoms or even without any diabetes eye complications, a screening test with a professional, whether an optometrist or ophthalmologist, should be done. So that's one. The second is controlling the risk factors. Of course, glycemic control or glucose control, right? So Diabetes Canada guidelines recommend targets for people with diabetes. For most people, the target is for the A1C test to be less than 7%. So if we get A1C of less than 7 and maintain that, there's much less risk of being diabetes eye complications. But also important is controlling the cholesterol and blood pressure. Not as important as maybe in heart disease that Robin mentioned. So cholesterol is much more of a risk factor for heart disease, but there's also an additional risk factor in eye disease, in diabetes as well. But the more diabetes eye disease is glucose itself. So that's one thing to keep in mind as well. And the third thing that we can do to prevent diabetes eye complication is actually managing the problem early. So the first sign that anybody has of any problems in the eye, even if you're not sure if this is important or not, it's important to seek management and treatment immediately and not take it lightly.
Thank you so much, Dr. Bajaj. That was incredibly informative. We have a question on foot care. So Dr. Ablaoui, a person on the floor had indicated they have shooting pain in their feet and toes and very heavy most days. However, there are no sores, but there's discoloration around the toes. Skin is very dry. So the person is asking what they should do, and do you recommend regular like pedicure? What is the way to get for all of the ailments that they have indicated?
Yeah, great question, Joanne. Thanks for sharing that. Now, again, of course, we can't make any diagnoses online, but it sounds from what you're describing that you have what we call clinical symptoms or of peripheral neuropathy. So it can range from the tingling, numbness, burning, but also loss of sensation. So I would suggest that, if you haven't had your annual foot exam, make sure that you have it, because the protective sensation needs to be checked. It's done using something called a 10-gram monofilament, which looks like a fishing rod, but is not sharp. And we basically kind of poke the bottom of your feet, see if you're feeling it. And it gives us a sense if your protective sensation is in place, so your defense mechanism. So I would say that would be the first thing. Diabetes educators, family physicians, specialists, podiatrists, and foot nurses can do that for you. So it's step one. The other thing, it's hard to comment on the discoloration, but it sounds like it needs to be looked at. It could be from different reasons. So I would say a podiatrist, is an option. Unfortunately, it's not covered in many provinces as part of the public healthcare plan. So depending if that is an option, otherwise, your public healthcare team should be able to at least do an assessment there. About pedicures, just a quick note. Whether your protective sensation is there or not, whether the circulation is flowing as expected or not, there may be potential harm from pedicures, especially where, and I'll just say this from personal experience, the water is always boiling hot. So in somebody where their protective sensation may not be there to give you the warning to pull out, you may get second-degree burns from that. So it's really important that it's done professionally. So podiatrist, chiropodist, they're named differently across provinces, or a trained foot care nurse, and various other professionals trained in that would be the best step. Diabetes Canada has a nice, quick one-pager, promise not too long, general do's and don'ts from a safety perspective, and it's readily available online. So hopefully that'll be helpful. I'm just going to jump in quickly to Verna's question about the brown staining. That's probably from pooling of blood, where the valves in our veins, which take blood back to the heart, may not be functioning. And just where the blood may pool in the legs, you may get that dark brown staining. If you get other reasons that you have swelling and the skin stretches or it's thin, there may be ulcers or wounds. So again, having a foot care nurse or a podiatrist look at it, or your family physician to point you in the right direction.
Thank you so much, Doctor. We have a question about muscle gain. In terms of Dr. McFarland, perhaps you could shed some light on this. Like, will muscle gain through weightlifting help control blood sugar, maintain healthy A1C, or does actually like a physical activity includes blood sugars? Like, in what point is it too much?
Sure. So it's a common question for me. One of the things that happens if you build up muscle is that because creatinine, which is our handy dandy way of measuring the level of kidney function from a blood test, the level of the kidney function, the level of the creatinine in the blood is a function of the level of kidney function, but also how much creatinine you make. And the more muscle you have, the more creatinine you make. But in this case, having more creatinine is actually a good thing, because generally speaking, having a bit more muscle is probably better than being depleted. So I often get people who come to me with a slightly high creatinine and they're working out. But when we do other ways of measuring their kidney function that don't depend on muscle mass, their kidney function is totally normal. So don't worry about it. If you're going to work out and put on some muscle weight, it's probably a good thing. It will make your serum creatinine go up a little bit in the blood test, but that does not represent a drop in kidney function, and we take that into account. And of course, physical activity of all kinds can be helpful in terms of keeping the weight down, keeping the blood pressure and blood sugars down. These are fundamental to diabetes, and central to the lifestyle part of the Diabetes Canada guidelines is a healthy lifestyle, as Robin had already mentioned, including regular exercise. I usually try to tell my patients to do at least 30 minutes of physical activity at least 5 times a week, building up to that if they are sedentary.
Thank you, Doctor. I have a question for Dr. Holden. If you're maintaining your type 2 diabetes with diet and exercise with no meds of an A1C, let's say 5.1, are you still looking at complication, or is there any risk? What do you recommend?
So if you've been told that you have diabetes, you've worked hard to lose weight, you've got your A1C test down into the normal range, then we actually, Dr. Harpreet Frajal knows even more on this topic than I do, but we consider this something called diabetes remission. And if you get into that category of diabetes remission, then you really have lowered your risk for developing the complications of diabetes.
Yes, Dr. Bajaj, could you also share some highlights into that, please?
Yeah, so diabetes remission is a fairly recent discussion Diabetes Canada and other societies have had. We have a new Diabetes Canada guideline chapter that is coming out in the Diabetes Canada annual conference on diabetes remission, which basically, as Robin mentioned, bringing down the glucose levels, so A1C, into the normal range, so non-diabetic range kind of A1C, without need for medications. However, this is not for everyone, and some people, as Robin mentioned already, the weight loss is what appears to be key in that, and early diabetes. So people who've had diabetes not for a long time appear to be the most or the better candidates, if you will, to try and achieve this remission target, which could be done with weight loss and certain low-calorie meal replacements or with bariatric surgery. But we'll have more on this 12-month diabetes remission. But as the point to be taken home is, as Robin mentioned, if you reduce your glucose levels, you're controlling the blood pressure, and the cholesterol is within the target range as well. All of those risk factors are reduced, and hence the risk of complications should be reduced as well.
Thank you, Dr. Bajaj. Dr. Ablawi, what is involved actually in a foot care exam when you see your doctor?
Yes, I was seeing that question. I was hoping we were going to pick that one. So we'll give you a quick tour on what that looks like. So you're in the office, you're going to have your foot exam. A question I commonly get is both socks off or one? So definitely both, if we want to count all 10 toes, both socks, shoes off. So 5 steps. The first one is feeling the pulse on the back of your feet to check your circulation, gives us a hint if there are any issues there. And then the second thing is the 10-gram monofilament. So that's that fishing rod where we have you close your eyes, touch different areas on the bottom of your feet, see if you can feel them. That gives us the answer on whether you have protective sensation. The third is we look at your full foot, including the heel and the back. So if you have hip or knee issues, let us know. We'll usually do it slowly just to pull it up, make sure we're getting that 3D view. The fourth is we look specifically for deformities or changes in the foot. So if you have a flat foot, if your toes are curved, or if there's any area that we think we may provide some direction in terms of better footwear, we'll suggest that. And then the fifth one is, please don't feel, don't take it personally if we touch your shoes and we flip it and we shake it. We just need to take a quick look into your soles and make sure there aren't any worn out areas, maybe some rocks or gravel that have made it there. And we may provide some input or point you in the direction of proper footwear. It usually takes less than 2 minutes. Many people apologize and go, oh, I don't know if I took care of my feet today, but checking feet saves and protects feet. So I will say we are more than happy and actually love doing feet exam and hopefully giving you that reassurance or giving you some informed information from the foot exam that we can take and have a strategic plan to reduce your risk of having complications. And there are lots of YouTube videos if you want to just get a visual on that.
Thank you, Doctor. This is a two-parter question for Dr. McFarlane. Are creatinine levels load dependent? And also, should a test be done when you have high levels of protein in the urine, or when should that test be done for kidney disease?
Okay, so maybe we'll tackle the second part first. So as with the eyes, your initial screen for kidney disease with the random urine test and blood test is done immediately upon the diagnosis of type 2 diabetes. And then if it's normal, is repeated annually after that. So every single year, you should be doing a quick urine sample into the random sample container and a quick blood test. What happens if it comes back abnormal? There can be fluctuations in your kidney function from one day to the next, especially if you have an intercurrent illness, if you're sick with something else. And for a variety of reasons, sometimes the amount of protein in the urine can go up temporarily as well and not actually be associated with kidney disease. So if one of your tests come back normal, your doctor will probably order at least 2 more urine tests, at least 2 more blood tests spread out over 3 to 6 months. And it's only if the tests are coming back consistently abnormal, either in terms of the kidney function, and if the protein levels are high consistently, if the kidney function is low consistently, that's when we would have a concern. The second part was load dependent, which I don't know if I totally understand the question, but I'm going to interpret that to mean, like, is it the more you lift, the higher your creatinine goes? And I suppose it would, in that, just as I said, the creatinine is also a function, the creatinine in your blood is released from the muscles, so it's also a function of how much muscle you build. If you're in an exercise program that's keeping you kind of more towards the lean and trim side, it probably won't throw off your serum creatinine any. But if you're doing a lot of heavy lifting and putting on a lot of muscle mass, the creatinine in the blood will go up. But I want to emphasize again that that's not actually a sign of the kidney function going down. It's just a sign that you're making more creatinine that day because there's more muscle in your body. Oh,
Siva, you're muted.
Siva, we can't hear you now.
I apologize. I was on mute. Sorry about that. This question is for Dr. Holden. If a patient has been taking metformin for 20 years and the A1C is about 6.4, should they continue to take it longer, or is it a lifelong medication? And is there any complications associated with it?
Metformin's been used for a very long period of time. It's considered to be sort of one of those basic foundational drugs for diabetes. People will stay on it for life. It's very well tolerated. Sometimes the complications are most likely when you first start taking it, and they tend to be like things like loose stool, sometimes abdominal cramping, but typically over time your body gets used to it. It can really help you keep the weight down, can keep the diabetes under control, even used in people who haven't developed diabetes, who have something called pre-diabetes to help prevent them from going on to develop diabetes. So I think if someone's been on metformin for long periods of time, they should stay on it if it's working well for them. Sometimes it can cause low B12 levels, so your doctor might want to check your B12 level periodically, but otherwise I don't think there's any concern about staying on metformin for long periods of time. Lots of people do.
Thank you, doctor. Considering it, looking at the time, I just want to ask, we've had a number of amazing, important questions for all these four amazing panelists. So the question that I have for all four of you is, working together, is there anything that you could advise if your patient, when they're coming for a checkup, what are the top three things that you would recommend for anyone with type 2 diabetes? To each doctor.
Maybe I'll go first, because these days we're a big fan of blood pressure readings taken outside of the office. So if you have $150 that you were not sure how to spend, you could buy yourself a home blood pressure monitor, or alternatively, you can go to your pharmacy and have it checked. Often the blood pressure in my office is higher. And so because blood pressure control is so fundamental to so many aspects of diabetes, help us out and bring in some readings from outside the clinic as well.
Thank you, Dr. Holden. Or to your Dr. Ablawi, please.
Sure. I'll jump in really quick. I'll just say that, I understand that complications just overall can weigh heavily just thinking about them. And I know working with people with diabetes, it keeps people at night, really impacts their quality of life. So I just encourage if you could share that with us. If we forget to ask about that, we'd like to know and hopefully try to, use us. And we're part of your diabetes team. We really care to work with you to reduce the risk of complications, maintain safety, and try to balance quality of life. And hopefully we can, in our roles, try to leverage at least the facts, share the information, and try to leverage some of the system support in place, which you don't have to shoulder on your own. And hopefully we can make this journey a bit better until we all wait for the final cure.
And on that, I'll just add that prevention is better than cure. So if we can do some of those things that we've discussed, the fabulous four, the other fabulous three panelists have shared as well, right? So test for the kidneys at least once a year, test the feet with the monofilament test with your doctor or your healthcare provider, other healthcare providers as well, once a year. And then eye tests should be done once a year or twice a year, or depending on if somebody has a condition, it could be more frequent as well. And then for your heart, as well as for the other complications, controlling those risk factors, so controlling the glucose levels, but in addition, controlling the blood pressure, cholesterol. We've seen over the past 20 years, 2 decades, complications have come down. So that's the positive news. And I think if we keep, the medical advances coming and flowing and using it in our clinical practices, the complication rates will even come down further in the next 2 decades as well.
Beautifully said. Thank you, Doctor. And Dr. Holden.
I I think I've been doing diabetes care the longest on the panel here. I'm up to 32 years. This disease is totally different than it was when I started. There's so much we can do. Complications are not inevitable. As everybody's saying, there are things to do. So keep in touch with your healthcare provider. Come in for those regular visits and let us do our work.
Thank you so much, doctors, for giving your time today and all these fabulous questions to all of you who have posted them. And these are incredible questions. Unfortunately, we've run out of time. So I'd like to thank Dr. Holden, McFarlane, Dr. Bajaj, and Avaloi for answering all these amazing questions. I mean, we could have this room going for like another hour because we have so much to ask, but thank you so much for your time. And my name is Siva Swaminathan, and thank you all for tuning in.